Michaelidis. Well, now that it's recording, I'm going to start from all over, skipping the jokes. So good morning, everybody. Welcome again to one more Friday session with our team here at the Mayo Clinic in Florida. And today we have our pituitary session, the monthly session. We have two presenters. We got Dr. Loisos Michaelidis, and we got Dr. Chase that Chase Makovich. Okay, I was about to say that I just know Chase's first name, but now I just learned his last name. And they're going to be presenting two, different cases, but two very interesting cases in my point of view that hopefully will also be equally enjoyable to everybody here. Is Dr. Simpson logged in, Diogo?
Hey.
Hi, Dr. Simpson. How are you? I was just giving introductions while we were getting you to log in. But perfect.
Thank you.
Now we got Dr. Sampson. I'm not sure if we got Dr. Chaichena here with us already. I know he has. We have a couple of cases going, so he probably is going to join soon. I see Dr. Pless. I see Dr. Reiner, and I see a bunch of our colleagues. So thanks everybody for joining us, and I'm sure we're going to get more people as we go. So who's going to go first? Oh, Loisos. Loisos, please go ahead.
Thank you, Dr. Almeida. Can everybody see my screen okay?
Yeah.
All right. Good morning. I'd like to start the case by thanking all the providers that participated in the care of this patient, and not limited to Dr. Chaichana, Dr. Almeida, Dr. Donaldson, Dr. Sampson, Dr. McKenna, Dr. DeBiase, and Dr. Alvarez. So to start the case, this was a 31-year-old woman that presented to our endocrinology department in October 2021 with a previous history of menorrhagia, irregular menstrual cycles, and galactorrhea. She had already had elevated prolactin on previous labs of 97 and an MRI dating back to August 21. She had a primary past medical history of polycystic ovarian syndrome that was diagnosed back since she was 19 years old, and she didn't have any other surgeries. This was the MRI that was done back in August in a different institution. And here we can appreciate, this is a coronal T1 sequence after contrast, and we can appreciate a hypoenhancing lesion on the right side of the sella with the normal pituitary push to the left side and remodeling of the roof of the sphenoid sinus. Now, at this point, due to the imaging and the
can I ask you something, Loisos, if we go back to that MRI, just because you described the MRI very well in my point of view. Do you think there is invasion of the cavernous sinus in that scan?
So at this point, no, it's very clearly demarcated that is very out of the cavernous sinus.
Okay, good. So we often use a classification that you probably heard called NOSP classification for those, right? So if you were to classify this, what do you think this would be? What type of NOSP this would be?
I think this would be a grade 0 because it's not touching the cavernous sinus.
I think it's touching the medial wall, so I would classify it probably myself as a 1.
Okay.
I would use 0 for once more medially located, but anyways, point for discussion later. Okay, this is just to illustrate some of the points. And of course, this is nowhere close to the optic nerve. Just show us the optic nerves just for the audience.
So this would be the optic chiasma right here. So perfect. I would assume.
No, that's fine. The optic chiasma. Yeah. So you have CSF between them. So that's good. Okay, please go ahead.
Yes. So at this point, because of those findings on the MRI and the previously found prolactin levels, we ran another lab work with prolactin and was again found to be elevated at 64. And at this point, she was initiated on medical therapy with cabergoline oral intake. This was at 0.25 to 25 milligrams twice a week. But unfortunately, she couldn't handle it and she had some adverse effects with dizziness and brain fogginess. Eventually, she was switched to vaginal use, which again had some burning sensation and then was put back to oral intake. Unfortunately, she couldn't handle oral intake of cabergoline, and that's when she was referred to neurosurgery. And at this point, cabergoline was discontinued in September 22.
Can I make a quick comment, Loisos?
Absolutely.
So many people are not aware that the absorption of bromocriptine and cabergoline is actually very high from vaginal use. And so sometimes by not having to go orally and through first pass metabolism, some of those intolerant symptoms can be resolved using this. But in her case, it didn't work. So
thank you, Dr. Simpson.
Can I ask you a question, Dr. Simpson, as well? Like, so regarding some of those side effects, like especially like the fogginess and dizziness, in terms of percent, usually, like how common are those for cabergoline?
I couldn't quote you a percent from the literature right now, but I would
Sure.
put it at about 1 in 10 of my patients.
I see.
Having
And
treated
that's
probably 1,000.
I see. And that's usually like it's really like for our understanding, like so that's one of those that can be improved. For example, this patient's taking a very small dose, as I understand here, but like it's one of those as well that also improve as the the nausea, etc., can improve with the decrease in the dose, I assume.
Sometimes it can, and the other thing I have patients do is take their doses at night before bed or with their dinner meal, so that they're actually sleeping through when the peak symptoms come on. But that doesn't always work either. And I usually find if they have symptoms when they started, it often stays around. Unfortunately, it's not something they get used to. So it's really patient specific, and you just have to warn them about the symptoms.
Thank you, appreciate it.
Thank you both. And then this is the physical examination, a presentation to the neurosurgery department. At this point, she was dealing with some nipple discharge, and she had some daytime sleepiness, loss of balance, and headaches. Now, this is the prolactin progression of the patient. This is before she presented to us at the point of presentation to our endocrinology department. This is while she was on cabergoline, so we can appreciate that the prolactin levels had been normalized, but unfortunately she couldn't tolerate the drug. And then this is when she was discontinued from cabergoline and referred to neurosurgery. Now, everything else was within reference values such as cortisol and ACTH and thyroid levels. The elevated testosterone we can attribute to polycystic ovarian syndrome. And I don't know, Dr. Sampson, if you would like to comment further on these results.
I think also we have an endocrine fellow that has worked on this, right?
Yeah, Dr. McKenna.
Correct, yeah. I think you summed it up nicely, but everything aside from the prolactin, this preoperatively was within normal limits. The testosterone we did attribute to her PCOS and hyperandrogenism. She had not been consistently taking OCPs.
Thank you. So at this point, because of her not being able to tolerate the medical therapy, the plan was for surgical resection and disease control through an endonasal endoscopic transsphenoidal approach for tumor resection, and goals to obtain tissue for diagnosis and, of course, disease control. Now, these are the images prior to surgery. This is a coronal T1 post-contrast. Again, can be seen the hypoenhancing lesion on the right side of the sella with the pituitary pushed to the left. The disease had been stable over 1 year, so we don't appreciate any other changes. And this is the coronal T2. I don't know, Dr. Almeida, if you would like to.
No, I think as we were talking about, like especially functioning adenomas, this relationship with the cavernous sinus and even like just the medial wall, the cavernous sinus becomes very important. So we got the adenoma here, which is pretty easy to see, even easier without my drawing. So I'm gonna delete that because I didn't like my drawing. Okay, and then you got the medial wall, the cavernous sinus here, right? And in this other side, it would be here. So you see that this case, according to the image, we have a tumor that, in my opinion, is in contact with the medial wall, the cavernous sinus, but according to the image, not invading the cavernous sinus. To me, the T1 helps quite a lot to see this adenoma, of course. And if you go to the T2, I often have an easier time identifying the walls with the coronal T2. So I really like that coronal, but you see more difficult to identify the tumor, despite the fact that you see some of those white dots here on the floor. With this consideration, then when you think about microadenomas or microprolactinomas, I think it's fair to divide it in two categories. One, that will be located in the center of the sella, or called central adenomas, that are not necessarily central, but are those located and surrounded in 360 degrees or so, but by the floor, by pituitary gland tissue. And that's important because we know that those have a pretty high chance of surgical success or disease remission after surgery. And those that are laterally located, such as this one, that are in contact to the medial wall in one of the sides, those ones, according to literature, previous experiences, so the chances of control will remain very high, but usually it's quoted about 92%. I mean, I would quote 90 to 92%. The big thing is really if there is invasion of the cavernous sinus or not. And as you're going to see in the surgical video, the big thing, in my opinion, is if there is signs of a tumor in that wall. If there were no signs of tumor invading that medial wall, I believe that it's fair to just coagulate the wall and the contact gland. But if there is some signs of, though, yeah, I think that there is some tumor here attached to this wall, then I think we got to go and proceed with the medial wall resection. So let's see what we did in this case, I think.
Thank you.
I mean, or I don't know if Dr. Reiner would like to add additional comments as well.
My only comment, can you hear me okay?
Perfectly,
Yes.
yeah.
My only comment is we don't usually talk about it abutting the medial wall. That's interesting that you bring that up, and we'll definitely add that to our repertoire.
I think you're muted, JB.
Can you hear me now? Sorry.
Yes.
So basically, when we this is all related with this I wouldn't say new, but let's say more elaborated technique more recently. So we have been doing that like since last year or so, and we have got like those. I think right now we got 13 or 14 cases, including 22 only. I haven't looked at 23. But that has had a very, very nice positive impact in our functioning pituitary adenomas in terms of results. And the medial wall really, it's this concept that sometimes when we have, especially in Cushing's and acromegaly, that those patients, we got a nice result and they come back with recurrence, the hormones start going up, and often the site of recurrence is that tumor left attached to that medial wall. And then the concept is that we can go surgically and open the cavernous sinus, isolate the medial wall, and resect the medial wall, which is what we have been doing in a series of cases. There are different techniques, one for small adenomas like this that are in contact, and that's a selective resection of the medial wall. And then there are for the big adenomas that kind of go through the medial wall into the cavernous sinus, and then in reality that medial wall is very thinned out and it's already kind of like destroyed by the tumor. But in a case like this, we can literally expose all that anatomy of this medial wall and actually remove it in situ pathology, and then Dr. Gentoff can confirm to us if that has been positive or not. And in fact, we're prospectively collecting that data so we can publish our results hopefully in the near future.
Thank you, Dr. Almeida and Dr. Reiner. Proceeding to the sagittal. Proceeding to the sagittal, T1 post contrast, we can again appreciate the pituitary gland on the left, and then more to the right, the lesion. And then sagittal T2, similar findings. And then we also have a CT, which Dr. Reiner mentioned that, this is just based on this CT, you could appreciate that there was a pituitary adenoma prior, and then this was based on the remodeling of the roof of the sphenoid sinus, which we can appreciate right here on the right side.
Oh, can you go back, Loises, for
Absolutely.
the CT scan? This sinus has a nice anatomy. So I think we have a bit more time today. So let's do a quiz.
Absolutely.
It's always good to do that. No? Can you scroll a bit more in this game? Go kind of forward. Yeah, okay, go one back. One more. Yeah, okay, let's stop right there, right here. So you see this structure right here? And then there is a similar structure right here.
Yes.
Right? So what are those?
This would be the anterior climate process.
That's the anterior clinoid process, exactly. This is a part, this is the base of the anterior clinoid process, which is the optic strut. And you see that here, there is a bit of pneumatization on this side and also a bit of pneumatization on this side, okay? But that's the attachment of the anterior clinoid process. In this anterior clinoid process, of this part that I'm gonna call optic strut here, is gonna separate two structures. One that is gonna be right here. You can see better when we scroll, but okay to keep it right there. One that is right here. And then you have another one that you can see here, and that you can see right here. So what is the name of this one?
So this one should be the optic canals.
Perfect, exactly, optic canals. And then what is this other one that is located inferior lateral to the optic strut?
Then on this side should be
They're the same name, just different sides. I'm gonna help you with this one. So this one, this is the superior orbital
fissure.
fissure, exactly. So this is an important concept in anatomy because the optic strut will separate you from the optic canal to the superior orbital fissure. And then if we follow the lateral wall of the sphenoid sinus, you're gonna see this exactly, foramen rotundum, perfectly, because this guy is looking at you. And then if you scroll, you can scroll the image towards us a bit. Go, keep scrolling. I'm gonna go back. Sorry. Go. Okay, stop right there. But no, the other one. Okay, and here in this side, you can see that there is a small thing canal right here, and another one that is going actually on this side right here. What are those?
Would that be the median?
Yeah, good, very good. Perfectly. And you see here, of course, a septation. And it is just to remind us of some of those bony landmarks that will be important for us when we are looking into this. But for the sake of time, let's go ahead. It's just because this was a nice picture there. And let's continue going for the video.
Thank you, Dr. Almeida. So the comparison between August 21 to December 22, when she came to neurosurgery, we can appreciate almost a similar size of the lesion without any significant growth. At this point, of course, our first differential would be the prolactinoma, but we cannot rule out possibility of meningioma or a metastatic tumor or a non-functional tumor. Now here we have the endonasal endoscopic transsphenoidal approach. Starting in the right nair, we have the nasal septum medially and then laterally the middle turbinate and the guana. Here we have identified the ostium to the sphenoid sinus with enlarging the site by removing some of the mucosa to the ostium of the sphenoid sinus. Then we are cauterizing some of the posterior septum. And these will be repeated both on the right side and the left side. Now we are on the left, in the left nair, we're repeating the same process with the ostium to the sphenoid sinus and performing a posterior septectomy of the membranous portion and then the bony part. Here we're drilling away the bony part of the septum to gain access to the sphenoid sinus.
Very good. So this was a very nice approach done by Dr. Donaldson. Unfortunately, she couldn't join us today. You can play, Loises, that's fine. And then you see here, she's just mobilizing the mucosa, and then we're gonna jump ahead and start with our work at the skull base. So you see that the small adenoma, so small chance of needing a flap, so could just mobilize the mucosa. And here you can stop the video. No, I need to see the part with no mucosa a bit forward. Perfect. So repetition is the key always. So it's kind of like I'm gonna go and gonna draw again. Here we got the sella. And then when looking at this, we got to identify some of the landmarks. So here, we're going to have the optic canal on the left side. We're going to have here the optic canal on the right side. And here we're going to have the carotid, the clinoid segment of the carotid on the right, clinoid segment of the carotid on the left side. And this here will be the clival recess. And here we got the paraclival ICA on both sides. And of course, the cavernous sinus will be occupying this, actually this space here. And here the same thing. So with this, you know, kind of like 3D X-ray vision, it's kind of like you got to identify that anatomy before your surgery. So in this surgery, the goal, it's a microadenoma. So we don't need to expose carotids on both sides and things like that. But we need to get a view of the blues of the medial wall. I'm sorry, the anterior wall of the cavernous sinus on the left. Same thing on the right. Superior intercavernous sinus and a bit of the inferior intercavernous sinus. So we can see the blues on the four corners, more importantly, so on this side. So that's where we're going to stop for drilling. So go ahead. So usual fine diamond drill, going, you know, clockwise and anti-clockwise fashion to elevate a square bone. And then we're going to expand to the right side until we got to the point of the blues that we were just talking about. And once we got those blues, as you can see on the right side and on the top especially, so we can go ahead and open the dura or the cell. And the idea here, once again, is to cut this dura, but separating the dura and preserving the pituitary capsule, and certainly so preserving the pseudocapsule of an adenoma, which we have in this case. So there's always some venous blood with microadenomas, which is completely fine. We just have to mobilize it and understand where the venous blood is coming from, so you can put some pressure and you can work around. You don't need to worry about it too much. And you see that here, we're gonna already have the adenoma. You can keep playing the video, but here you can see the adenoma on the right side, and then you see the gland on the left side. So with that, then we gotta mobilize, we gotta mobilize the adenoma, right? The idea is to remove it in an extracapsular fashion. So you see that the first thing we do, instead of touching the adenoma, we mobilize the gland. And the mobilization of the gland is beneficial because then you don't disrupt the pseudocapsule of the adenoma. And then using this straight knife, the straight dissector go on the top, which is the separation with the diaphragma, and then separation with the gland, using the same maneuvers in 180 degrees. After that maneuver is completed, close to completion, you can separate a bit more the gland itself, and then you can go to the bottom as the next step. And then you have to separate the adenoma from the floor of the cella, from the dura. And then the last piece will be some attachment to the medial wall. So you just go in that direction, and then you bring this tumor from the back part. And then that's it. So, you know, it's just being delicate with the capsule, really. And then some Hollywood movie maneuver here. And hemostasis afterwards. And once again, it's a functioning adenoma. So we're gonna inspect. The surgery is not over. Want to make sure that there is nothing left. And you got to be really very obsessive compulsive about that. So gonna inspect and inspect. So here what you see on this side, that's the medial wall of the cavernous sinus. That looks pretty clean. But so you're gonna coagulate some of the gland on the right side and gonna elevate the gland to see if we're not missing anything. So that's what you see happening right there. And once that is, so the medial wall looked pretty clean to me with no signs of residual tumor, and then gonna go and gonna coagulate that most lateral aspect of the gland as well. So in our point of view, this inspection of the medial wall, it becomes really, really important, because if there was signs of tumor infiltration in that side, I would extend the bone opening, open the dura, the anterior wall, the cella of the cavernous sinus, and selectively remove that medial wall of the cavernous sinus as well. And this is just hemostasis reconstruction with, you know, Jalfone and some dura substitute. We really didn't have any CSF leaks, so this is more than enough. And I believe that's it. And that's fine, Loisos. I think this is mostly it.
Thank you, Dr. Almeida. So post-op imaging, this is a sagittal T1 post-contrast. We can appreciate here the surgical cavity. Let me scroll a bit. This would be the normal pituitary on the right side, on the left side, and then moving to the right side, we can see the resection cavity. And then this is the packing for the hemostasis. Coronal T1 post-contrast. Again, we can appreciate the resection cavity on the right side. And then we have the pathology, which as expected was that of a pituitary adenoma of lactic cells with these uniform cells that are characteristic for adenomas. And the diagnosis was, again, prolactinoma with low proliferation index of less than 2%. Now, the results on postoperative day 1, we can see that the prolactin had normalized, which remained stable even in postoperative day 7. I don't know if Dr. McKenna or Dr. Sampson would like to comment further on these results.
Yeah, I can just say that we also look for diabetes insipidus, and the sodium was at a good level, no evidence of that. And just like you said, cortisol at a good level, that she did not require hydrocortisone upon discharge.
Thank you.
And her follow-up appointment in January, her prolactin was still normal at 20, which I think is reasonable given that she's on birth control pills, because there's going to be some drive of the oral estrogen from the pills. And for women, this can, the prolactin can be up to 26, 27. So I'm very happy with this cure for sure.
Thank you, Dr. Sampson and Dr. McKenna. And then again, just a small prediction, on postoperative day 1, there were no acute complications from the surgery. There were no signs of diabetes insipidus, no CSF leaks, and normalization of prolactin levels. On postoperative day 7, again, no diabetes insipidus or hyponatremia, and didn't require hydrocortisone. And last follow-up in January, again, the patient still had normalized levels of prolactin with no signs of galacturia and overall doing very well. So thank you, everybody. And thank you, Dr. Reiner, as well, for being here with us today for the radiology part.
Thank you, Lois. Great work. Very nice presentation. And if any comments, we can have maybe a couple of questions before we transition to the next case. And if not, we can go ahead and have the next case, and then we can jump into a few discussion points afterwards. Dr. Q, I see you. I just see you there right now. Good to see you, sir.
Same here. Thank you. I'm so sorry. I was actually putting in the chat. Thank you. So great to see everybody here and to see you guys continue to work. I am a few minutes late because I'm in Washington, D.C. for some NIH and some grant opportunities. And I was just at a meeting with the leadership right now for some other major endeavors at the Mayo Clinic. So I was meeting with Kent and AJ and our team, actually. So thank you. Keep going. I'm excited. I'm here for a few minutes, and then I have to jump to another meeting at 8 a.m. for one of our program project grants as well with our team. So keep it going, please. I want to learn.
Good, boss. Thank you.